Assalamu alaikum all. It's 10:05. I'm a stickler for time. So we're gonna go ahead and get started. For other people who'll be joining late, they can, I guess, watch the video if they so wish. So today's talk is gonna be rather dry and boring, so I apologize ahead of time. But it's a very important topic. So we're gonna be talking about thromboembolism prophylaxis. So the issue here is that with VTE prophylaxis, it's particularly the timing of prophylaxis that is a point of contention at times, and that's between there's a vast difference between the medicine consultants and the surgical consultants as to when prophylaxis should be started or should be held before or after a surgery and so forth. So that's a bone of contention between us quite a bit of the time. But I hope in the end, the main gist of this talk is to sort of let us understand that our main goal, no matter what field of medicine we're in, is for patient safety. And thromboembolism or VTE is one of the major and most common things that we see in the hospital. And it's particularly well reported in the Western world as opposed to Pakistan, which I'll get into in a little bit. So this is a little outline of the talk. We're going to go through the definition, incidence, the risk factors, the recommendations and risk stratification, and then our therapy options that we have. So what are your definitions? So everyone knows a DVT is formation of one or more blood clots in one of the body's large veins. So one of the common misnomers here is, can a DVT actually occur in a superficial femoral vein? And yes, obviously it can, because the superficial femoral vein is a deep vein. Now, what about embolism? An embolism is when a portion of a blood clot breaks loose and travels into the bloodstream. Now, what is a thromboembolism? So DVT and PE are commonly grouped together and sometimes referred to as venous thromboembolism or VTE. So one of the things that we need to realize is that you can have DVTs are not only limited to your lower extremities. They can actually occur in the upper extremities due to things such as instrumentation, such as like placement of a PICC line, placement of subclavian triple lumen can also lead to a DVT as well, things of that nature. So we need to be aware that it's not only limited to the lower extremities. Now, most common cause of a PE is a DVT. So 90% of thrombi are dislodged from the deep veins in the calf. Some originate in the pelvis, particularly in pregnant females. So those are people that we have to look out for, because even if they have signs and symptoms that we're concerned that they may have a PE, and your lower extremity Dopplers are normal, you need to proceed with further imaging up into the pelvis to ensure that there is no origin of a clot or origin of a thrombus in the pelvic area. Other instances are fat emboluses that can occur when long bones are broken, as in such orthopedic trauma cases. Now, coming to your incidence. Now, Pakistan, I did a literature review, and there's only a total of around about 81 studies or so that revealed the incidence of VTE in Pakistan. And the range that's been described in that lit review is very low. It's like 2.6 to around 12%. Well, when you look at the West, there is much more evidence, much more literature from the West, and it shows that hospitalized patients have a 10 to 48% risk of VTE. Now, why is that? Now, let me talk to you about why that is, because Pakistan has, first off, we have limited data, and the percentages are likely very much underestimated. And it's probably due to our uninformed medical personnel who are just not looking for it. So we're not aware that DVT, PE, VTE is present, and it's obviously underdiagnosed. Now in the West, the reported incidence is much higher because there's more awareness. And that awareness arises mainly from a couple of facts. One is that there are quality metrics in the West. Your physician rating, your pay, your bonuses are directly linked to any complications that occur during a patient's hospitalization and to the patient's length of stay. So when you're looking at all of that, when you're looking at those quality metrics, the physicians over there make sure that a PE or a DVT is going to lengthen the hospital stay, is going to complicate things financially for them, limit their reimbursement. So they definitely have it, have DVT prophylaxis up front. And another thing that helps out is there are order sets in the West. Everything is fairly well computerized. All the EMRs have particular order sets where you go through it, and everything has GI, DVT prophylaxis. And it's just a click away. So it's not missed, where it's missed here because more so of our written orders. Now, looking at the absolute risk of DVT in hospitalized patients. Now, this is data taken again from the US, and it shows the absolute risk of DVT occurring in hospitalized patients. Now, the highest risk still remained in critical care, in the critical care population, the major trauma population, and our orthopedic patients. As you can see, critical care 10 to 80%. I know that's a wide range, but it's because sometimes these are missed, and there's such variability in this as well. Now, what's the consequences of an unprevented VTE? So the consequences are you can have a symptomatic DVT and PE. The major consequence that we all are trying to avoid is a fatal PE. There is the inherent costs of investigating symptomatic patients, the risks and costs of treating unprevented VTE, and the increased future risk of recurrent VTE. And then you have chronic prosthrombotic syndrome as well, which is chronic leg swelling, discomfort, or dermatitis and leg ulcers that can occur in a patient who's had a DVT. Now, prophylaxis is the most appropriate to reduce the sequelae and is better than screening strategies and reliance on like your signs and symptoms of early DVTs. So if you start prophylaxis early, particularly at the time of admission, you can prevent all of this. Now, this is data taken directly from the CDC, but I want to note one thing, there is no precise number of patients that are affected by DVT or PE. The CDC does not have an accurate number. Their estimate is that there are around 900,000 Americans each year are affected by blood clots, and there's around about 100,000 cases of premature death due to those blood clots. Now, of note here, I want you guys to focus on the second portion here. 50% of blood clots are healthcare associated. And there are many reasons that one of them, that patient may develop a blood clot, but again, 50% of them are directly related to recent hospitalization, surgery, and most of those do not occur until after the patient is discharged. So the Centers for Disease Control has said that VTE is a leading cause of preventable death, is the leading cause of preventable death, hospital death in the US. It is the fifth most common cause or reason for unplanned hospital readmission following surgery, and is the third most common reason for hospital readmission following hip and knee surgery or knee surgery. So what are the risk factors that we look at? So everyone always knows, okay, malignancy is a risk factor, cancer therapy, you can say oral contraceptives, smoking, but there are other things as well. Surgery, obviously trauma, immobility, which we all know of, inflammatory bowel disease, varicose veins, central venous catheterization. All of these are some of the risk factors that predispose a person to have VTE. Now, if you guys can all reach back into your physiology, pathology type of days back in med school, remember VIRCHOW'S TRIAD. So what you have is you have stasis, you have hypercoagulability, and vessel wall injury that lead to thrombosis. Now, when you look at it, it's easy to break it down into the causes. So the causes of a hypercoagulable state: malignancy, pregnancy, estrogen therapy, trauma, inflammatory bowel disease, sepsis, nephrotic syndrome. And then for your circulatory stasis, you can have AFib, you could have LV dysfunction, you can have immobility, venous insufficiency, varicose veins, so forth. And then the vascular or the vessel wall injury is from the trauma or the surgery, from venopuncture, from chemical irritation, from any heart valve disease or replacement, atherosclerosis, and then indwelling catheters. Now, what is the rationale for thromboprophylaxis? Now, the rationale is always because of the high prevalence of venous thromboembolism, because of the adverse consequences of venous thromboembolism, and then the efficacy and effectiveness of thromboprophylaxis. So it is, most hospital patients have one or more risk factors for VTE, and these risk factors are cumulative. So when you look at it, when we look at the efficacy and effectiveness of thromboprophylaxis, it's highly efficacious in prevention of a DVT. All right. It is also highly efficacious in prevention of symptomatic VTE and particularly fatal PE. DVT prevention prevents PE, and then there's a cost effectiveness as well. So risk factor stratification, when you're looking at it, you can either look at it from the individual approach or a group specific prophylaxis approach. So the individual approach, the drawbacks are it's unable to confidently identify individual patients who do not require prophylaxis. It is subjected to, it has not been subjected to rigorous clinical evaluation and is logistically complex and likely associated with suboptimal compliance. Now, when you look at a group-specific approach, for most patient groups, sufficient number of randomized controlled trials, clinical trials are available to allow strong recommendations in regard to the benefits and risks. So based on the above, do we have any guidelines? Well, yes, we do. There were guidelines that were released from CHEST. And this is the American College of Chest Physicians. And there was, the original guidelines were released in 2012, February 2012, in the 9th edition. That was the 9th edition of the guidelines. They were updated further in February 2016, and they were more recently re-updated in August of 2021. So now looking at this, you guys have all seen this, you all know this is your level of recommendations and your class levels and so forth. So I'm not going to go into this in much detail but I will be referring to this as we go over the recommendations. So recommendations. So when you're looking at it, you have prevention of VTE in hospitalized patients. So all hospitalized patients should be evaluated for both bleeding and VTE risk within 24 hours of admission. Again, VTE is venous thromboembolism. So you're looking for that risk within 24 hours of admission. A key here is upon transferring level of care. So all hospitalized patients, if they're moving from the IPD to the ICU to the CCU, vice versa, what have you, when you're transferring level of care, they should be reassessed for their risk for VTE. And then periodically during the hospital stay. So that is a class 1 level of evidence B. Now, there should be a documentation of your initial bleeding risk in the medical record within 24 hours of hospital admission or post-surgical procedure. And that's a class 2B level evidence C recommendation. Now, what about evaluation? How are you going to go about the evaluation of bleeding risk? Now, here's the caveat. There is no universally validated model to assess bleeding risk. There are factors associated with bleeding risk in medical patients, and those factors are active GI ulcer, platelet count less than 50, or bleeding in 3 months prior to admission. Now, when you look at the continued evaluation of bleeding risk, the factors associated with bleeding risk in surgical patients. Now, this is a class 1 level recommendation B is active bleeding or previous major bleeding. Renal failure, which is indicated by a creatinine clearance of less than 30. Hepatic failure, which with an INR greater than 1.5. Thrombocytopenia, acute stroke, or uncontrolled hypertension. Now, when you're looking at it from the medical aspect, so evaluating patients for the VTE risk, what do we use from the medical aspect? There's one thing that you could use, which is the modified PADUA risk assessment model, which is a class 1 level B evidence. As for the surgical patients, it's a different risk assessment model. You can use the CAPRINI risk assessment model to look at it. So looking at it, here's the PADUA risk assessment model. So this is for the medical patients that you have. So you have a point system there on your right-hand side. So if a patient's critically ill, they get 4 points, all the way down to if they have a BMI of greater than 30, they get 1 point, so forth. And you can read that as well as I can say it out loud to you guys. So I'll let you guys look at that and read it yourself. But the thing is, you look at the cumulative points. So if a person has greater than 4 or greater points on that scale, and they're high risk for VT, and they're high VTE risk and low bleed risk, and the key is, again, low bleed risk, they should be on pharmacologic prophylaxis. If they're high VTE risk and high bleed risk, they should be on mechanical prophylaxis. Anyone less than 4 is considered low VTE risk, and VTE prophylaxis is generally not indicated or needed. Now, VTE prophylaxis, still the regimens that we look at for high risk VTE medical patients, again, medical patients. So our gold standard, the one that we use very often here, are your unfractionated or low molecular weight heparin. So you can have your heparin, 5,000 units every 8 or 12 hours, so BD or TDS, whichever you prefer, or enoxaparin, which is clexane, 48 milligrams sub-Q every 24 hours. Now, if a patient has renal impairment, the creatinine clearance is less than 30, you continue with the same dose of heparin, but you drop the enoxaparin down to 30 milligrams sub-Q. Now, if the patient has extreme obesity, if their BMI is greater than 40, the recommendation, which is a class 2A recommendation, is to give enoxaparin BD, 40 milligrams BD. And in low body weight patients, if they're less than 50 kg, it's enoxaparin 30. And that, again, is a class 2B indication. Now, looking at evaluating it from the surgical aspect, so looking at the CAPRINI risk assessment, you have a table in front of you. It shows you what things give you 1 point, which give you 2 points, which gives you 3, and which gives you 5. And then for women only, you have down there, you have if they've been on oral contraceptives, they're pregnant or postpartum, and if they've had a history of stillbirth in the past, spontaneous abortion, whatsoever have you. So you calculate the points based on that table, and looking at it, if a patient has 0 points, they're very low risk, and the recommendation from that assessment model is early and frequent ambulation. If they have a score of 1 to 2, they're considered low VTE risk, so mechanical prophylaxis is sufficient. If the score is 3 to 4, they're moderate risk and low bleed risk. Pharmacologic prophylaxis is generally reasonable. And then if they have greater than 5 points on that scale, they are high risk for VTE and low bleed risk. You're going to use mechanical and pharmacological prophylaxis. The key is and pharmacological prophylaxis. And then if they have points greater than 2 and they're high bleed risk, it's just mechanical prophylaxis alone. So again, with the surgical patient, you're looking, here's the treatment options that you have. Again, it's the same as it is with the medical patient. So enoxaparin, 40 milligrams sub-Q every 24 hours, that's a class 1, or heparin, 5,000 BD or TDS, which is a class 1 as well. If they're renal impairment, it's the same thing as in the medical assessment risk model. For bariatric surgery, so it is 40 milligrams sub-Q every 12 hours, which is the same as what I went over on the medical perspective. If the BMI is greater than 40, you're going to use 40 milligrams of enoxaparin every 12 hours for VTE prophylaxis. If a patient has had major trauma, it's going to be enoxaparin, 30 milligrams sub-Q every 12 hours, and that's a 2A, class 2A level of evidence. And then if they have abdominal pelvic surgery for cancer, it's going to be 40 mg every 24 hours, and that's a class 1 level. Now, looking at orthopedic patients. So when we come to orthopedic patients, you can break it down into total hip arthroplasty or total knee replacement. So if you're having a creatinine clearance greater than 30, you can use enoxaparin again. Here's where we originally see the DOACs, or the direct oral anticoagulants, coming in. So you have your rivaroxaban, which can be used at 10 milligrams once daily, or apixaban, which is 2.5 milligrams twice a day for VTE prophylaxis. Then you have fundoparinox, which can also be given, which is 2.5 milligrams sub-Q every 24 hours. Or you could go with the old tried and true method, which is warfarin, and you're aiming for a target INR, but that is so hard. It's not really even used from that perspective anymore. Now, looking at your total knee replacement, you could go with aspirin, but that's a class 2B indication. The class 1s are, again, enoxaparin, 30 milligrams every 12 hours. Again, so the difference between hip and knee, with knee, you're going to give enoxaparin 30 milligrams every 12 hours, and that's a class 1. That's a class 1 indication. Now, looking at rivaroxaban is given, again, 10 milligrams daily. Apixaban is 2.5, and then same thing with the fundoparinox and the warfarin. Now, let's say a patient refuses parenteral prophylaxis. Let's say they refuse, no, I don't want to get stuck with sub-Q injection, so forth. Then you can go ahead and give them apixaban 2.5 twice a day, or rivaroxaban 10 milligrams once a day. Now, what if you have a patient who has a history of heparin-induced thrombocytopenia? So then unfractionated and low molecular heparins are not indicated. That's a class 3. So you can use fundoparinox in that instance in those type of patients. Now, what about extended duration VTE prophylaxis? So patients who are undergoing bariatric surgery, or who have recently undergone bariatric surgery during that hospital admission, they have a high VTE and a low bleed risk, and the BMI is greater than 55, or they are an enoxaparin 40 milligrams sub-Q every 12 hours for 10 days following the surgery. Now, what about if they have abdominal or pelvic surgery for cancer? Now, in those patients with a cancer diagnosis who have received a traditional laparotomy, and they're greater than 60 or less than 60 with a history of VTE, they would require extended prophylaxis. And that, again, is enoxaparin 40 milligrams every 24 hours for 28 days post surgery. And that's a class 2B recommendation. Now, what about extended VTE prophylaxis in orthopedic surgery? For total hips, it's usually 10 to 14 days, and that's a class 1. So again, you can use the rivaroxaban 10 milligrams daily, or the apixaban 2.5, and then total knee, it's the same, 10 to 14 days, and that's also class 1. If they have undergone hip fracture surgery, again, 10 to 14 days, and that is also class 1. Now, what about monitoring? How are you going to monitor all this? So we're going to monitor the platelets. So before you start anticoagulation, you want to get baseline levels, and then baseline levels within 48 hours after starting. You recheck the levels within 24 hours after initiating prophylaxis, and then every other day thereafter. Now, if platelet count decreases by greater than 50 from a baseline or falls below 100, then you should consider heparin-induced thrombocytopenia as a possible cause. Now, your blood CP, you can get that. You can obtain a baseline before initiating prophylaxis, and then recheck blood CP every 3 days. Now, coming to your VTE therapy options. Again, you have unfractionated heparin. You have low molecular weight heparin, which is enoxaparin or clexane. You have the pentasaccharides, which is your fundoparinox, which can be used. You have your direct oral anticoagulants, which we have rivaroxaban, which comes as Xarelto except here in Pakistan. You have apixaban, which comes as Eliquis in America, but here it comes as Apixaget. You have dabigatran, which I still don't think is available here, but it's available by the trade name of Pradaxa in the West. And then you have your vitamin K agonist, warfarin. Now, what about mechanical prophylaxis? So you have graduated compression stockings or your TED hose, which I don't really think are that great. You have your sequential compression devices or your intermittent pneumatic compression devices, which are much better to be used. And let's say if they can't even use any of those, you have venous foot pumps. Now, for particularly high-risk surgery patients with multiple risk factors, pharmacological methods should be combined again with mechanical prophylaxis. So those are for high-risk surgery patients, which we discussed when we went over the CAPRINI risk assessment model. Now, the use of mechanical methods for patients with high bleeding risk, when bleeding risk decreases, you can substitute or add the pharmacological therapy. So you could initially just go with this if they have an initial high bleeding risk, and then when their bleeding risk decreases, you can add on your oral prophylaxis or your subcutaneous prophylaxis. Now, looking at your sequential compression devices, this is what they look like. You have your venous foot pumps, which is as such, which aren't as good, obviously, as your SCDs. Now, what are your contraindications to mechanical prophylaxis? Looking at the contraindications, number one is severe peripheral arterial disease or ulcers. If they've had a recent skin graft, if they have peripheral arterial bypass grafting, so that still falls under peripheral arterial disease, or if there's severe local problems on the leg. So if they have gangrene, they have dermatitis, they have untreated infected wounds, things of that nature. Now, SCDs and intermittent pneumatic compression devices are suitable, but graduated compression stockings and TED hose are not suitable in the following patients. Patients admitted for stroke. Now, why is that? Now, TED hose are contraindicated in CVA patients because there have been two studies that have been done. The studies are called Clots 1 and Clots 2. So clots in the legs of stockings after stroke. So what it is these are two large randomized clinical trials. Clots 1 compared thigh-high stockings versus no stockings. And the outcome was that thigh-high stockings were ineffective at preventing the combined outcome of asymptomatic, ultrasound-detected, and symptomatic proximal DVT. While Clots 2 looked at comparing thigh-high with below-knee stockings. And there were fewer cases of DVT with thigh-high stockings. But these two large randomized clinical control trials have shown that TED hose are contraindicated in CVA patients. Now, they're also contraindicated in severe leg deformity or morbid obesity because they can't really get a good fit. And then in severe peripheral neuropathy, they should not be used. Now, what are your contraindications to pharmacological VTE prophylaxis? So your absolute contraindications if they're already anticoagulated. So you have a patient that's admitted with AFib and they're already on apixaban, rivaroxaban, or warfarin, or they have a mechanical valve and they're already on warfarin. There's no need to add on pharmacological VTE prophylaxis in those patients. Another absolute contraindication is if they have an active major bleeding, meaning 2 units or more of blood or blood products transfused within 24 hours. If they have recently significant bleeding within the last 48 hours, obviously if they have thrombocytopenia less than 50, or they have an inherited or acquired bleeding disorder, then it's contraindicated. What about your relative contraindications? Now, your relative contraindications are surgical procedures with high bleeding risk, so head and neck surgery or neurosurgery within the last 2 weeks, recent GI or genitourinary bleeding, recent CNS bleeding, intracranial or spinal lesion deemed by neurosurgery to be high risk of bleeding, or uncontrolled systolic hypertension with readings of 230 or over 120 or higher. Those are relative contraindications to VTE prophylaxis. So now coming to the timing of VTE prophylaxis in surgical patients. So let's say you have a patient on Clexane. The timing to stop the VTE prophylaxis prior to surgery. For Clexane, you stop it 12 hours preoperatively, and then you start it then daily thereafter. So then following the surgery, the next day you restart it, or immediately within about 8 to 12 hours after the surgery, you can restart it. Unfractionated heparin, you can stop it up to 2 hours preoperatively, and then 8 to 12 hours thereafter, you can restart it. For the DOACs, you can go with rivaroxaban. You can restart it 6 to 10 hours after surgery when hemostasis is achieved, and same with apixaban. Now, you have all heard about IVC filters and so forth. Now, IVC filters are a vascular filter, so it's a medical device that's placed in the IVC to reduce the risk of PE. Now, there's no strong evidence to support prophylactic IVC filter placement in patients with contraindications to both pharmacological and mechanical prophylaxis. And it's strongly recommended that temporary IVC filter placement only be reserved for use in exceptional circumstances. So a patient who's very high risk for VTE and that have absolute contraindications to both either pharmacological or mechanical prophylaxis. Now, this is what an IVC filter looks like. You go in through either the right or the left femoral vein to place it, and you place it underneath the renal veins. Now, coming to the summary. So I know this was a long talk. I went rather quickly because there's a lot of stuff to cover, but thromboembolism is underdiagnosed, it's underreported, and it's very, very much preventable. All patients should be screened for VTE prophylaxis at the time of admission, and particularly at the time of transfer of level of care. There are the risk scores that I went over. So you have the PADUA risk score for medical patients, you have the CAPRINI risk assessment for surgical patients, and then I went over pharmacological and mechanical prophylaxis. And finally, my own thing is hospital order sets. If we have hospital order sets that have it on there that VTE prophylaxis at the bottom, so it has heparin, Clexane, you can even throw in your DOACs if you wish, and it's ticked so that we don't miss it. So we don't miss it because we want to prevent these fatal events, particularly the fatal PEs that can occur during hospitalization. Now, I'll be open for any questions if you guys have any. Otherwise, thank you for this opportunity. Okay, if there are no questions, then I'll say thank you guys, and I guess we're done.